To understand post-surgical pain is to understand how invasive surgery is. And to understand it, you really have to understand what neuroplasticity is. Now, Dr. Varagos is an anaesthetist friend of mine who's a well-trained acupuncturist, and part of this talk is on the concept of neuromodulation. You can take the pain out of the post-operative experience and you replace it by a modulated sensation, which is often heaviness. People tell me their leg feels a bit heavy, but I have no pain because I've successfully modulated their experience. Now, my own interest in this comes from, I hope that I can play the cello to a level where I can play in a string quartet with some friends. And my training was that the chance of that, with a limited number of brain cells being decreased regularly, would be very remote. But neuroplasticity is something that is around, and most of our friends will understand that concept. And this is the first book that I read on that subject. So neuroplasticity is the brain's ability to reorganize itself, and it does this by forming new connections. So the big hope is if I can practice the cello regularly and smart, I can actually become better at playing the cello. This is a magazine you may have found in the news agencies recently, and that's got quite a big section on acupuncture. So this is what the community out there are reading. This is quite an extensive article on the brain and the spine and the peripheral sensation, and a big section on acupuncture. And when you operate on someone, it's handy to understand, we're using this musical theme through it, it creates such a loud noise in that sensory nervous system that it causes a maladaptation and misinterpretation of that sensory stimulus. So what you're doing is like heavy metal in your ear, and something's got to give, and what gives is our sensory system, which is a highly refined, very subtle processing device. And what Laurie and Dennis are talking about is reversible neuroplasticity, in that associated with surgery, you get this changes the sensitization of the peripheral sensation apparatus. And if you look at that more specifically, medications like pregabalin and gabapentin actually can block that change in the sensation sensitization, and they work on the dorsal horns. So what Laurie and Dennis are talking about is a reversible neuroplasticity. And I'm so sad that Laurie's not there, who I know quite well, because I'd love to have a discussion about this. And I believe he's made it all too simple for the audience for me to believe that there aren't other problems. And the point of this talk is that there are other problems. So we all have our own method, and this is the one that Chit Ranawat showed me. But if you look at surgery in general, there's at least a 10% incidence of post-surgical pain between 3 and 6 months. And James mentioned that, but didn't go on with the theme. And if you look at inguinal hernias, the commonest problem post-inguinal hernia repair is not recurrence of hernia, it's pain. And it's not pain that's trifling pain, it's pain that's very disabling. And that may last for 3 to 6 months. And it's felt, it's very important, that the ilioinguinal nerve is part of that problem. If you look at breast surgery, the relevance of the node biopsy is to try and limit the axillary clearance, because that's associated with very significant post-operative pain. And of course, we all know about thoracic surgery, the intercostals, we know about amputations. So post-surgery pain, take it from me, in the literature, is at least a 10 to 15% outcome for our surgeries for the 3 to 6 months afterwards. In orthopedics, we've managed to reinvent this a bit. We've got our own words for it. We call it unexplained pain. But it's the same sort of thing. And in the England and Wales Joint Registry, the incidence of unexplained, or I'm going to call it neuroplastic pain or neuropathic pain, is 18.2%. The American reference there is the Brandes, which is 13%. This is literature. I can give you the articles about these. The other thing about this is that the revision surgery in these people has a very low rate of success. So what happens with this is that we get this neuropathic pain, and it's a maladaptation of the nervous system due to the surgical stimulus, and the whole sensory appreciation of pain has changed. It's gone from a high threshold to a low threshold stimulus, We have spontaneous pain. The sensory system suddenly starts to light up. Slight touches associated with this very significant pain, and so it goes on. So the sort of stuff, if you doubt this for a minute, I'd refer you to the review article in the Lancet, clinical investigations. The things that I'm telling you now are all in these journals, but they're not the sort of journals that we normally read. And the stuff that we read in the standard orthopedic texts have an emphasis on mechanical joint replacements, not on this aspect of surgery. So you can say that pain persisting after wound is healed is the result of an injury to a peripheral nerve. And iatrogenic neuropathic pain is probably the most important cause of chronic pain 3 to 6 months after surgery. I'm sorry if you're not getting the message, but this is reality. This is in the journals, not the stuff that we read, but it's in all the journals that I can refer you to. So the features of neuropathic pain is you have an injury and you have a central sensitization. I'm going very quickly through this because I've been told to move on. Neuropathic pain has a very distressing component to it. It makes you feel sick in the stomach. So what happens to these folks is that 6 months after surgery, they go to see the local doctor and say, I've still got this awful pain. And the local doctor will say, well, you're stuck with it, aren't you? They're not seeing the surgeon, the physiotherapist. Everyone's lost interest in the whole problem. They've stopped the analgesics because they're told they're a bit wimpish. They have very much reduced emotional and physical support. And the other thing is that the initial pain scores might be quite good. It's sort of 6 weeks, 8 weeks, they might have reported reasonably satisfactory pain scores. Now, all the medial approaches that we have to the knee involve a nerve, the saphenous nerve. And this is the reason why we develop this neuropathic pain as a consequence of that. So my approach to the prevention of chronic pain, to prevention of this neuropathic pain, is to say, okay, if I use the lateral incision, I'd avoid the saphenous nerve. I neuromodulate the patients with acupuncture and pregabalin. I use emeryl cream, which is a eutectic cream of local anaesthetic applied under plastic in the area of the saphenous nerve to reduce the afferent input. I use pregabalin, and that's the thing that's been used for a long time for chronic pain, and it certainly evolved over a period of time. But with pregabalin on board, the patients were very, very different in terms of their movement. They didn't have that apprehension of moving their leg, and they were sort of just did it. And as Laurie said, if you're talking about early mobilisation and you're taking the fear factor out of the nerve, out of the leg, the rate of DVTs is significantly reduced. So what pregabalin does, or Lyrica does, it actually blocks that sensitization and blocks the uptake of the neurotransmitters, and the calcium channels are not turned on. And so it's actually designed to block the dorsal horn neurons sensitization. Now, acupuncture has become a sort of an important part of all this. I use it perioperatively. The thing about acupuncture is that it has no side effects, so you can use it in all comers. And it's most lovely to use it in an older person who you might be concerned about the opiates. And most of my surgery now is opiate-free. They don't require any opiates at all because we use the combination of acupuncture perioperatively and pregabalin and emeryl cream. What acupuncture does is well established. It produces adenosine, which is taken up by the receptors and blocks the afferent input. And the pregabalin acupuncture, it takes out the pain, it modulates the pain, but preserves the sort of still protective sensation that we need. And so my multimodal pain management process is using perioperative acupuncture, the subsynovial injections we've talked about at length. Dexamethasone is an important part of that, and so you can read on. But the majority of these surgeries are opiate-free. These people are on Panadol. Now, these are just some videotapes of surgeries. This man is 24 hours after his lateral incision and pregabalin and acupuncture. And to me, he sort of doesn't talk about pain, he talks about the leg feels stiff. So I'm rushing through this, but I've been given the direction to rush through it. This is a man who is 24 hours after knee replacement, and I think I'm seeing a person who's quite happy, he's quite bemused by the fact he's having his image taken on the video, but he's not distressed. He doesn't have the cognitive problems that go with pain. This is a man who's about 3 days after his surgery, and they actually use a bike. I have a sort of a stationary bike that they do, but this is what he does at 3 days. Must have had some Plexane too, I think. Not everything's perfect. This is a guy who's about 5 days who's about to go home. But I draw your attention to the fact he doesn't have a football of a knee. He has a sort of a, not a very swollen leg. He's had a lateral incision, and that's him sitting in a bed, and I disturbed him because he was reading the paper. But this is not rubbish. This is real time what these people are like. And you can see that he's quite comfortable doing that movement, and he'll do a sort of a forward press for you in a minute. I'm not a great believer in sending patients home early because you don't know what the home environment's like, and people this age don't normally have such a wonderful home environment. This is the last one, a man who's about to go home. He's 5 days after a knee replacement, being modulated with acupuncture, with pregabalin and the emeral dressing. So I think he's quite safe to go home, you know, and he's independent to the degree where he can look after his own sort of interests. He doesn't need to be a load on the family. But I'm drawing your attention to the fact how sort of it's not a painful experience. He's not going to struggle because of pain limiting his range of motion. And to me, he seems very, very much at peace in his brain. He's not being stressed by it all. Thank you.